Correct diagnosis will lead to correct treatment. In the case of hyponatremia, it could be caused by so many different conditions. So, it's important to make accurate diagnosis so that we can help the affected person appropriately. Together, let's go through hyponatremia and how to make accurate diagnosis. Hi everyone, thanks for listening to my presentations. Today I will continue on hyponatremia, and this will form hyponatremia 2, and it will be all about the diagnosis. If you haven't listened to hyponatremia 1, which was all about causes, signs and symptoms, please check my channel, and then you'll be able to follow systematically. Okay? Hyponatremia 2, all about diagnosis of hyponatremia. Let's go. Okay, in the course of this presentation, I'll be going through certain diagnoses, and here I have listed what you are likely going to come across, like hypovolemic hyponatremia, hypervolemic hyponatremia, isovolemic hyponatremia, syndrome of inappropriate antidiuretic hormone, hyperglycemia, induced hyponatremia, hypotonic hyponatremia, renal failure, Thiazide induced hyponatremia. Still on the list will be heart failure, liver cirrhosis, cerebral salt wasting, adrenal insufficiency, self-induced water intoxication, psychosis, polydipsia, long-distance race or marathon, street drops, severe hypothyroidism, and reset Osmostat. Diagnosis. Here, to make accurate diagnosis, we will start with a thorough history, physical examination, and of course, laboratory investigations. And we'll be going for the value of sodium and other electrolytes, but specifically, before we can say, oh, this is hyponatremia, it means sodium level will be less than 135 milliequivalent per liter. And of course, we want to know what the value of glucose is. It might be high. Okay, there is what we call corrected sodium. And someone will ask me, what is corrected sodium? Well, mathematically, you can have corrected sodium as measured sodium plus the product of 1.6 times glucose minus 100 divided by 100, or measured sodium plus 0.016 times glucose minus 100, or sodium in milligram per dl plus glucose in milligram per dl minus 100 divided by 100 for glucose greater than 100. You can pause and go through this. So if you go through a lot of literature, you're going to get different ways to calculate that. So I have brought out 3 here, so you can choose one. Okay, you have corrected sodium value estimated, right? Then, if your value is within normal range, you are likely dealing with hyperglycemia. And your diagnosis here will be hyperglycemia-induced hyponatremia. Okay, you can mark that somewhere. That's number 1 diagnosis. If the corrected sodium or glucose is low, then ask about post-operative condition. For example, if this is post-prostatic or uterine surgery, we need to find out. Then history of monitor use, that is osmotic diuresis, right? Or intravenous immunoglobulin administration. We need to find out. Okay, if monitor has been administered or intravenous immunoglobulin has been administered, then we need to measure serum osmolality. If it is low, then the diagnosis here will be hypotonic hyponatremia. Let me explain again. Monitor or intravenous immunoglobulin administration in this patient, and the response is yes. Then measure the osmolality. If the value of osmolality is low, then we are dealing with hypotonic hyponatremia. Okay, with impaired glomerular filtration rate, then we are dealing with renal failure. So we've had about 3 diagnoses right now, right? Okay, if there is no impaired glomerular filtration rate, then we need to find out, have you used diuretics recently or you are on it right now, particularly thiazide? Then we will advise, stop the thiazide. If the level of sodium is now better, then the hyponatremia we've been dealing with is secondary to the thiazide use. Therefore, the diagnosis will be thiazide-induced hyponatremia. But if there is no history of thiazide here, and there is no edema, and there is no ascites, then we are dealing with hypovolemic hyponatremia. Almost 6 diagnoses right now. If thiazide is stopped, or thiazide is not even involved here, and there is edema or ascites, then we could be having heart failure or liver cirrhosis. Making 8, right? Then we have to look for signs of hypovolemia. For example, decreased blood pressure and increased heart rate. If that is the case, that is hypovolemic, then we should measure the level of sodium. Then we'll measure the level of urine sodium. If urine sodium is high, that is greater than 40 milliequivalent per liter, we are dealing with hypovolemic hyponatremia. And we need to find out, because now we are dealing with renal loss. Anything that will make urine sodium greater than 40 milliequivalent per liter is pointing to renal loss of the sodium. Okay, so we are going to review the history and of course medications. And here we will measure our cortisol in the morning and also do ACTH stimulation test. You can check my channel for adrenal insufficiency and an ACTH stimulation test. I have all those published already. And we will also ask about history of head injury. If there is head injury, might be dealing with cerebral salt wasting. And of course, the use of diuretics here. So it will be diuretics-induced hyponatremia. So all these conditions could lead to renal loss of sodium. Okay, if the value of cortisol comes back to be low, or ACTH stimulation test comes out to be positive, then the problem is with adrenal system, with adrenal gland. Then we have at hand primary adrenal insufficiency with glucocorticoids and mineralocorticoids deficiency. If the measured urine sodium is between 25 to 40 milliequivalent per liter, then we will do something different. We will give isotonic saline at 1 liter per hour and then remeasure the urine sodium. If after that 1 liter per 1 hour isotonic saline, the urine sodium is less than 25 milliequivalent per liter, the diagnosis is hypovolemic hyponatremia. Okay, so we then need to find out what is causing the decreased level of sodium and the volume. Are we dealing with diuretics use here? Any gastrointestinal bleeding? It might be concealed. Any third space loss, vomiting, and diarrhea. We need to find out. If there are no signs of hypovolemia, then we have to take urine sodium and urine osmolality. If it is less than 100, at least osmolality is less than 100, that result might be due to the response to the normal saline given earlier, or we are dealing with hypopituitarism. Urine osmolality is not less than 100 when we assay it, and not measured after we've given the therapy of the saline 1 liter per hour. Then we have to find out about some other issues. Ask this patient, any quick water consumption? If the answer is yes, yes, we are dealing with self-induced water intoxication. Or this is psychosis, polydipsia. Or this person has engaged in long race, for example, marathon. Or this person is on street drugs. Okay, there is no quick water consumption. Then we are still curious where the problem is. Maybe this is high fluid diet, okay? Low protein diet. This person is taking alcohol and we're now dealing with beer potomania. Tea ingestion, toast diet, we need to find out. If urine osmolarity is not less than 100 and urine sodium is greater than 40 milliequivalent per liter, then we need to check the cortisol level in the morning and also carry out ACTH stimulation test and also have thyroid function tests done, particularly thyroid stimulating hormone level. If AM cortisol and ACTH are abnormal, then the diagnosis is glucocorticoid deficiency in the face of adrenal insufficiency. But if both are within the normal range, then we need to wait for the lab to report what the level of thyroid stimulating hormone is. If it is elevated, then we are dealing with hypothyroidism. But before hypothyroidism can give us hyponatremia and it will be clinically significant, it must be a severe hypothyroidism. Okay, if thyroid stimulating hormone is normal or within normal range, or even low, decreased, then the diagnosis is SIADH. This could be nephrogenic SIADH or reset Osmostat. Reset Osmostat is all about a change in the plasma osmolality leading to hyponatremia or hypernatremia. And That will warrant further investigations because we need to know the cause or causes. If urine osmolarity is less than 100 and urine sodium is not greater than 40 milliequivalent per liter, then we can give normal saline at 1 liter over 1 hour or more, and we measure our urine osmolarity and urine sodium. If our values are not of 10, which means if urine osmolarity is still less than 100 and urine sodium is less than 40 milliequivalent per liter, then our final diagnosis there is hypovolemic hyponatremia. If our values are of 10, that is, urine osmolarity is greater than 100, and urine sodium is greater than 40 milliequivalent per liter, then we have to check our cortisol level in the morning and have ACTH stimulation test done with thyroid function test, particularly with thyroid stimulating hormone level. If we pick abnormal cortisol and ACTH stimulation test is also abnormal, then the diagnosis is glucocorticoid deficiency in the phase of adrenal insufficiency. If the result comes back and the cortisol level and ACTH stimulation test results are within normal range, we have to wait for the result of thyroid function test. If that comes back to give us a raised thyroid stimulating hormone level, then we are dealing with hypothyroidism. But remember, I've said earlier that before we can have hyponatremia that will be clinically significant in the phase of hypothyroidism, it must be a severe hypothyroidism. But if the thyroid stimulating hormone level is not raised, then severe hypothyroidism is ruled out because subclinical hypothyroidism cannot give us hyponatremia that will be significantly and clinically important. So, TSH that is not raised here will be pointing to SIADH and reset Osmostat. And we have to look for the cause and causes. And with that, I've come to the end of this very presentation. The next presentation will be on hyponatremia treatment. That will be very important, just as the previous one and this one are both important when it comes to hyponatremia. The treatment is equally important. As a matter of fact, I think the treatment is even more important. Okay? Thanks for listening. Remember to share, remember to subscribe, and you are free to leave comments on my channel. I appreciate that.